So welcome to you all to the APOA Hand and Upper Limb Society webinar series of the APOA. This is the second webinar series of the year, and on behalf of the Executive Committee and also the Scientific Committee, I would like to welcome you all to join the meeting. This webinar is going to be on upper limb, including the shoulder, elbow, and wrist, and about the tendon problems. We have invited a significant different amount of panelists and speakers from all over the world to talk to you about rotator cuff, about hands in ECU management, as well as elbow distal bicep rupture. So without further ado, I would like to start the section and pass the ball to Jonathan.
Thank you, Margaret. Thanks, Margaret. Thank you. Again, welcome everyone for joining us to the Hand and Upper Limb Society webinar. We have shoulder, hand, and elbow topics as noted by Margaret. We'll progress that way. And then if you have any questions, please click the Q&A box if you have any questions. And at the end of every topic, every specialty region, we have an open forum Q&A, and please raise your hand or just share the Q&A. Just send us your question and we will try to answer everything. So before we proceed, I'd like to introduce my commentator. Together, we'll be handling the shoulder section. We have Dr. Shital Kumar Gupta. He's from India. He's actually one of the guardians of Galaxy Hospital, and he has he's been a consultant for sports medicine, sports authority in India and State Sports Academy, and is serving as national level teams of various disciplines in hockey, judo, karate sports, wushu, and taekwondo. He has performed more than 8,000 knee and shoulder surgeries, including complex ligament surgeries, in more than 2,000 national, international level players with various disciplines. I also would like to proceed introducing our speakers. Professor Jordan is from the USA. He is an orthopedic surgeon in Midwest City, Oklahoma, affiliated also with Midwest Hospital, Surgical Hospital in Oklahoma, and he finished his medical degree in Chicago Stritch School of Medicine. He's been a key part in one of the laboratories here in the Philippines as well, and he has dedicated his career as well in teaching orthopedics. He has expertise in treating arthroscopy, rotator cuff injury, and arthritis, and he's also done a lot of biomechanics in children's biomechanical ambulation and everything. And our second speaker to talk about double row repair of rotator cuff is Takman Wong. He's a clinical professor in the Department of Orthopedics and Traumatology and chief of the Division of Sports and Arthroscopic Surgery at the University of Hong Kong. He has specialties in orthopedics and traumatology, and his clinical interests are in trauma, hip rehabilitation, trauma surgery, tumor surgery, rotator cuff bioaugmentation, cuff rehabilitation, sports medicine, and ACL injuries. Without further ado, we can proceed with Prof. Jordan to talk about single row rotator cuff repair.
Thank you, Jonathan, for that kind introduction. So they'll put up my slides here. So he asked me to discuss single row versus double row. Last time I was at the University of Santo Tomas in the Philippines, and he was kind enough to let me go first, which is always the easiest spot. Anyhow, the goals of all cuff repair is what you see here, and then of course is tendon to bone with normal tension in a broad contact area. The question is, what's the best way to achieve that in our patients? Cadaver studies, as you all know, we all read the same literature. The double row is better in terms of contact area. Clinical studies, however, the results are equal. The first proponent, or the biggest proponent of, if you could slow down the slides, please. The biggest proponent of the single row repair was Steve Snyder. Southern California Orthopedic Institute. His friend and colleague, however, Steve Burkhart from San Antonio, was the person who popularized the double row repair. They both report excellent results. Single row repair has the advantage that it's a faster surgery. It's a less expensive surgery because you don't use as many anchors. It's an easier revision. So it has those advantages. Next slide. The double row repair, I think you may have skipped a slide, has the advantages of a broader contact area. There's times when a single row is your only option, and that's for a retracted tendon because you can't get the tendon lateral enough to do a double row. There's cases where you can't even get it to the tuberosity, and an easy way to help solve that is to remove some of the joint surface. You can safely remove up to 1 centimeter joint surface with no loss of motion postoperatively. Next slide. So the disadvantages of your double row, of course, is it's more anchors, which means it's more expensive. It's extra OR time. And once the medial row, or if the medial row fails, it's very hard to recover from because those anchors are typically very close to the musculotendinous junction. Next slide. Could you advance the slide, please? So when in doubt about tension, it's very important to go to single row. The most common reason for failure of any cuff repair, but especially single row repairs, is overtensioning. So it's something that has to be carefully avoided. Next slide. So when a single row fails, it fails by the tendon pulling through the sutures. The anchors in this day and age don't fail. The sutures don't fail. What it is the tendon rips away. And so the question then is how to prevent that single row failure. Next slide. So I like to think of it, how can I make a single row work like a double row? How can I increase that contact area? And the number one way to do it is to do an inverted stitch and to be sure to use mattress sutures. Next. So Christian Gerber has published that the cause of failure for the most part is that you're in weak tissue. And he made the point that you want to be right at the edge of the cable. I do that, as I'll show in a second, with a spinal needle. It's quick, it's easy, it's inexpensive, but you're just right at the edge of the cable, so you've got strong tissue to help get the tendon back laterally. Next. So I do this with a spinal needle, and I use PDS because I have it. Nylon works as well. And then to pull your tape or your suture through. Next. And you can do this right at the edge, and then you have a firm stitch that will invert the tissue when you go up into subacromial space to pull it laterally. Next. So you bring a spinal needle through, bring your suture through, grab it, pull it out your cannula. Next. Use that to tie the two together as you see here, and just pull it through the cuff. Next. And you'll end up with something that looks like this. In this particular case, I knew from the MR that there was a large bursal-sided tear. And I think the advantage of doing it this way is I know that my articular-sided suture is coming through good tissue. When you end up taking down the cuff, sometimes you can't really see where that underside suture is coming from. And here I have no doubt I'm in good tissue. And then you go up in the subacromial space, turn it into a mattress stitch. Next. As you see here. And then when you bring that through the anchor, it's going to invert that stitch and pull it down with a suture that's not going to rip out through the tendon. Next slide. There are other ways to increase your contact area. One that is easy, very fast and easy to do is a subacromial spacer. This is something that was popularized in or developed in Israel, used in France by Laurent Lafosse, is now available in the United States. And next slide here it is. The acromion is on top. The rotator cuff is on the bottom. It goes in through an inserter. It's rolled up, so it looks like this. And then you fill it up with saline so that it then keeps downward pressure on the cuff, holds the humeral head down. It was initially designed as a substitute for reverse total shoulder. And the idea was it would hold the humeral head down in proper relationship with the glenoid. It's actually more useful as a way to augment rotator cuff repairs. So that when you blow it up, next slide, or fill it up, this is what you see. This is usually your last picture you get because you're looking through the saline here. Cuff is again on the bottom. A couple of caveats about using this is, number one, you should not do an acromioplasty, and because you don't want it to escape out anteriorly. Two, you make sure that it's enough posterior so when it is inflated, it's all underneath the acromion, again, to prevent this anterior escape. Next slide. One of the things that has been a secondary benefit is these patients rehab much quicker than normal. This is a patient who's 1 month post cuff repair with a subacromial spacer. It's hard to tell which shoulder it is that was repaired. In fact, it was his right shoulder. And at 1 month, he already has this much active abduction. Next slide. Other things he can do, Steve Snyder talked a lot about this microfracture. There's articles in literature say it doesn't make any difference. He always was showing slides. It's quick, it's easy. You take the same instrument you use to create your anchor hole and just put it in about 2 millimeters. These do bleed. He always referred to it as the crimson duvet. And I like to do it only because it's fast, it's easy, and maybe it makes a difference, and at least it doesn't do any harm. That's another way to increase the contact area and to bring the healing out further laterally. Next. So failure causes with our single rows are it's in weak tissue. It's using simple, not mattress sutures, and most importantly, that there's too much tension on your repair. So next slide. So my thought, I always tell myself, if I do my single row right, it will work as well as a double row. And the other thing is I make a point of not inhibiting my healing. Next slide. So the other thing I do is I always put the scope in when I'm done to make sure I like my contact between the top of the cuff and the humeral head, so that if not, I always have the option of doing a transtendon medial anchor, but that's not something I routinely need to do. Next paragraph. Next slide. So another important area is how we rehab them. If you read the articles in literature, there's very little discussion about how they're rehabbed, but there's been a lot of work on that. Probably the most important is to go slow in your rehab. The studies have shown that early rehab and late rehab, the results are the same, except for one variable I'll talk about in a minute. Definition of slow rehab is you don't start physical therapy for 6 weeks. Now, I always start passive exercises, pendulum exercises that are patient-directed immediately at 1 week, but I don't have them in doing any strength-type training for 2 months. There's a whole series of articles in the JBJS early in the year, in January, about supplements for promoting healing. The critical amino acids are arginine and leucine, and in the States at least, it's something that's called Impact AR, which is a Nestle product, and that's been documented in cancer patients and in cardiac surgery patients to decrease the incidence of wound dehiscence. There's not a lot of good orthopedic articles, but there are some documenting improved healing also. Some articles on doxycycline, which inhibits the matrix metalloproteases, which can inhibit cuff healing. And the other important thing besides slow rehab is no anti-inflammatories. There's been cat studies with Celebrex celecoxib, dog studies with naproxen, human studies with ketoprofen. Multiple studies all show that they inhibit the healing process. In the States, there's a big push to decrease opioid use, and there's talks about adding anti-inflammatories immediately post-op, but multiple studies have suggested that that does inhibit the healing. Next slide. Here's an article just in this month's Journal of Arthroscopy and Related Research, and what they said is that the stiffer shoulders have better tendon healing, and what it really means is that they slow down the rehab, and there's that and because of the stiffness, and so it turns out that this just sort of corroborates what's been in the literature for a number of years. Go slow, it's much safer than going fast. Next slide. So as I like to say, it's not a re-tear rate. We always talk about re-tear rates. It's a, you never let it heal in the first place rate. In my own personal series, my revision rate for single row repairs is only 4%. So again, I thank you for your attention. Hopefully there's some value that you got out of this talk.
Thank you so much, Prof. If you could hold on, after the next speaker, we'll have our open forum. Now we'll proceed with Takman Wong from Hong Kong talking about double row rotator cuff repair. You're still on mute, Takman?
Yeah, thank you.
Thank you.
Thank you. Yeah, thank you, Jonathan. And yeah, and let me check. Can you? Oh, sorry. Okay, how to say I share again. Okay, can you see my screen?
It's opening.
Yeah, can you see it? Sorry, can you see it?
Not yet.
Not yet, because something wrong with my computer. So maybe you any questions from the floor first?
Do you have any questions, Shital? Any comments while waiting for the slides to be shared?
So my question to Professor Christopher, in single row repair, you always add balloon in all your cases, or there specific indication where you are going to add your balloon for single row?
No, I do not use it in all cases. It depends on the tear. The bigger tears are the ones that I use it on, which I think is where its greatest benefit is. As I say, it's very quick to put in. Honestly, not more than 7 or 8 minutes of extra surgery time. And the only problem is you need to err by going posterior when you put it in, so it does not escape out the front. But I think larger tears are where it is most useful.
And in traumatic cases where there is a young patient and there is a massive tear, so still you will go ahead with the single row, or in such cases, at least you will offer a double row repair?
That decision I make at the time of surgery. As I mentioned, I'll do the single row because actually the traumatic ones are easier because they've not retracted. It's quite easy to get the tendon back to its anatomic footprint. But then, as I say, I put the scope in at the end to make sure that I like my tendon bone contact. So I do the double row kind of backwards. I don't actually put in that medial row unless I see that I need it because I don't have good tendon bone contact.
And if we consider the re-tear rate, which has been given in the literature, particularly in the long-term follow-up, the re-tear rate in single row is around close to 55% as compared to double row, which is around 30%. So in your experience, what additional thing you're doing that your re-tear rate, as per the literature, is very high and your re-tear rate is very low? I mean, any special tips that we can understand to reduce our re-tear rates?
Well, I think the key is really my post-op program, and also maximizing the patient's nutritional status. They all get their vitamin D levels checked. They get their albumins checked. Those are corrected before surgery if there's a problem. But again, the slow rehab is the critical thing. If you read the literature, that the long-term results at 6 months, there's no difference between single row and double row in terms of re-tear. I think that, in fact, it's better with the slower rehab. And so I really think that that's probably the key to my success, is I just don't risk re-tearing it. There's the other thing that I didn't mention in terms of avoiding anti-inflammatories, at least now, is we have liposomal bupivacaine, which with a shoulder block will last 3 or 4 days. And so the patients get past that early period. There were some people who I've heard at meetings who say that they think the re-tear occurs in the recovery room as the patient's waking up and moving their shoulder because it hurts. And so that's another small detail to, if you can get a nerve block that'll last 3 or 4 days, which it can with the liposomal bupivacaine, that again probably is another useful adjunct.
Thank you
I
so
think
much, Prof.
Professor Tekmin Wong will
can-
defend the topic,
Yeah.
so I think he's ready with the talk.
Yeah, thank you very much, and sorry for a bit delay. And I'm going to talk about the double row technique in rotator cuff repair, and why, when, and how. So actually, what is double row? Actually, is quite simple, and is we put the medial row over the near the subchondral space, but at the same time we put another suture anchor over the lateral side of the greater tuberosity. So in order to compress the whole footprint, and the main purpose of it is to provide a better coverage of the footprint. And at the same time, we can provide a better fixation of the cuff repair. I think just like ACL reconstruction, we use double fixation sometimes. And of course, for all rotator cuff repair, it should be tension-free. This is very important. So double row means that there's quite a number of methods. The most common one that we commonly now use is transosseous equivalent suture bridge. Either this is a knotless or locked medial row. Or in the older days, there we have independent double row. That means we put a separate suture anchor over the lateral side of the footprints. So why double row? Okay, why we want to do double row? As Chris already mentioned, okay, if double row, then okay, we may spend more time on it, and we may have to say this the cost, because we need an extra suture anchor. Okay, either this is a knotless or knotted, so we may spend more time as well as we spend more cost on it. But of course, it's an advantage. First, it is we have about mechanical advantage. We can restore the lateral side of tendon to the footprints, and sometimes actually the double row can help us to cover the greater tuberosity as much as possible. And according to the literature, it can increase the contact area between the tendon as well as the footprints up to more than 60% compared with a single row. And of course, sometimes someone may ask, okay, if double row, whether the blood supply, whether there's any jeopardize. And according to another author in 2012, the blood supply is not compromised even double row repair. So this is the contact area between the most upper one is a transosseous, and the middle one is the single row, and the bottom one is the independent double row. So you can see from the diagram, okay, the contact area is much higher in independent double row fixation. How about the repair rate? So from Sugaya, and he did the retrospective in 2007 before, and find that the repair rate is much lower in double row technique. And how about Mihata in 2011? He compared the single row versus double row and transosseous equipment. And he find that transosseous equipment in large and massive cuff tear, the repair rate was much lower, it's just only 7.5%. And another offer, this is a level 1 study in 2010. This is a systemic review. We find that if the size is more than 4 cm, the repair rate is much lower in double row. However, even in the size is less than 3 cm, again, double row have a lower repair rate compared with single row. So how about clinical result apart from repair rate? This the below is level 1 study. All find that there's no difference in the clinical outcome between the double row and single rotor. So why we still do a double row? So this is quite a latest literature in 2020, and mainly compare with the outcome in a large rotator, small and rotator cuff tear between the transosseous double row and single row. And we find that for small tear, there's a no definite difference between single row and double row. However, when we compare we repair the tear, which is much larger, for example, it's more than 3 cm, then we find that double row have a better functional outcome. So you can, in summary, okay, for the repair rate, double row is much safe in case of moderate and large tear. And even for clinical results, although some level 1 studies suggest there's no difference, but however, in case of bigger size tear, then I would suggest using double row technique. So how about independent double row versus transosseous equivalent suture bridge? Clinically, there's no difference according to Dr. Chu in 2023. So again, why we still want to, when we do the double row, of course, sometimes it really depends on the surgeon preference. For me, for all rotator cuff full thickness tear more than 1 cm, I will use double row. Although paper suggests there's no difference compared with single row. And moreover, for moderate and massive cuff tear, I will choose double row in order to achieve a better outcome and reduce the repair rate. So how I do a double row? So this is a very large tear. So I will prepare the foot pinch first. I will use either a shaver or a burr to prepare the bone back of the foot pinch. And then I will use, most of the time, I will use suture anchor, but not all suture anchor, because the anchor is much stronger and more encouraged, especially over the osteoporotic bone. And sometimes we may have to tap the track as well. And then usually I will use two suture anchor over the medial side. And this is another one. Yeah, I will tap it before I put in the suture anchor. Most of the time I use a 4.5 suture anchor. But of course, it really depends. If the bone is quite osteoporotic, then I will use 5.5. And then I will start to suture the tendon using the suture passer. Okay, after I pass all the suture, and then I will tie a knot. Okay, I will tie the knot. And in this case, because this is a massive cuff tear, so after I pass all the suture, I will do the margin conversion. Okay, and sometimes, okay, someone may ask me, you do the margin conversion first, and before you put the suture anchor. Most of the time, I put the suture anchor before the conversion margin. Okay, otherwise, you may have difficulty to put the suture anchor. And then I will use SMC knot to tie over the medial row. Okay, after tightening, and then I will start to do the lateral roll. Most of the time, I will use a 4.75 knotless screw, just over the lateral side of greater tuberosity. Okay, this is the anterior one, and then I will do the another one over the posterior side. And how to say, finally, you can just light the mesh, covering the whole rotator cuff. But as I mentioned, the most important thing is we need a tension free. So I did a lot of release before any repair. So now you can see it's quite nice to cover whole the tendon. Okay, so this is the another patient, the final pictures of the double row fixation. You can see it's like a mesh, okay, covering the whole footprint. And I would suggest for the lateral row suture anchor, at least 1 cm. Okay, otherwise, if it's too separated, sometimes you may not able to covering well. And if too close, then I think sometimes it's quite crowded, and you may, how to say, make the dog ear quite easily. So for the rehabilitation, I think a bit different from Christopher. First 6 weeks, we start the patient with passive range of motion exercise, but at the same time, when the patient at rest, he or she has to keep the shoulder immobilized. And after 6 weeks, we allow the patient to have assisted active mobilization. And 3 months after the operation, we allow the patient to have active range of motion exercise. So this is another patient. You can see the patient with a massive cup tear. He had a shoulder. This is a 61 years old lady. He has a shoulder dislocation resulted in massive cup tear, complicated with pseudo paralysis. So this is a 1 year post-op. You can see after arthroscopic double row repair, you can see the patient quite happy. She could elevate the shoulder, and there's not much limited in the range of motion in external rotation and internal rotation. So in summary, I think double row fixation can provide better coverage of footprints in order to achieve better healing. However, okay, so far level 1 study, we cannot see any significant difference in clinical outcome, even with the small tear when compared with a single row. To me, I would do a double row, especially this is a moderate and passive cuff tear, because according to literature, you achieve a better clinical outcome and lower repair rate. So this is the end of my presentation, and thank you for your kind attention.
Thank you, Takman. The floor is now open for your Q&A. Excuse me. We have one question in the Q&A box from Justin Chow. Any tips on anchor fixation problem when the bone is too soft for osteopenic osteoporotic bones?
You mean double row or medial row or both?
Either, both. Yeah.
Both. Okay. I would say for the lateral row first. If lateral row, sometimes the greater thoracic is the bone is quite osteoporotic. First, we can use either the bigger screw. Secondly, how to say, you may put the lateral row more distal. Okay, because the more distal, the bone may be much harder. And for the medial row, you have to a bit how to say subchondral, because the subchondral bone is much stronger. So I would suggest you to put the medial row much medial as possible. Yeah.
So thank you for your talk, Professor Wong. I think the one question that was mentioned in the question answer box is, while you're tensioning on the lateral side, and if your medial anchor pull outs, and then what is your bailout situation?
Okay, I think for if while you put the lateral row screw and find that there's a pull out of the medial row. So
Yeah.
I think it's really depends on how to say, depends on the situation, because sometimes it may pull out. So if pull out, then I may have to revise. Okay, we may have to put the bigger screw again over the medial side, and then we do the lateral row again. But of course, sometimes it's quite consuming. So that's why for lateral row, I will not over tension. Okay, don't
Agreed.
over tension it, because you over tension it first, there's a risk of pull out over the medial row. And secondly, this is just my impression. Okay, sometimes I may worry about the blood supply of the tendon. So I feel tight, then I will stop it. Okay, yeah, don't over tight over the lateral row.
So Professor Wong,
With your-
the criteria in the literature is 3 centimeters. So how do you judge 3 centimeter, anteroposterior or mediolateral? And do you measure the tear size every time, whether to decide for a single row or a double row, or it's just
Okay,
on
not really. I seldom exactly measure the exact size. But for me, as I mentioned, I love double row. So for all cases, full thickness more than 1 cm, then I will do double row, no matter how big is the size.
Professor Jordan, anything to share with your years of experience on the osteoporotic bones with the single row repair?
Well, both of us are saying the same thing. Over tensioning is bad and needs to be
Yeah.
avoided. That's number one. Number two, we both agree if it's osteoporotic bone, use bigger anchors. So there's really not much difference between my experience with the retracted tears is that, frequently I cannot get them lateral enough to even consider doing a double row. So that, that's where I said that taking off, sometimes I have to actually create the footprint by taking out part of the articular surface so that I have some place to actually bring the tendon down to. There's not much difference between what he and I are saying. I've had good success with single rows, but I think it's some of the details. Always use mattress stitches because they don't pull out of the tendon nearly as easily. By starting the sutures on the bottom, it inverts the cuff so it has better bone contact. And so I think those little details may make a difference in making a single row work for the most part as good as a double row.
Thanks so much, Prof. And we don't have any more questions. Anything to add, Shital? Thank you for joining us as well, Shital. Thank you for your comments.
Thank you. One last question to Professor Wong. you're trying to bring a retracted tear up to the medial row. You're able to bring up to medial row, but not exactly up to the lateral row. You're in between somewhere. So what would be your plan? You will go for a Dr. Jordan single row repair, or still you will just put an offloading anchor on the lateral row?
I will sometimes it's just how to say according to Burkhardt and my friends Ben Cha. Most of the time, even how to say more than 85% of cup tear. Okay, even massive cup tear, we can how to say repair. We can repair without difficulty. So in case we really have a difficulty to how to say repair with a large of tension, then I will follow Christopher. Just we how to say medialize the foot pins, and then I will just put the single row, avoid over tension. Yeah.
I think our time is up. Thank you, Shital. Thank you so much, Takman from Hong Kong.
Thank
and
you.
thank you very much as well
Thank you.
to Professor Jordan. It's early in the morning, and happy Thanksgiving as well, Prof. Thank you for joining us.
Thank you.
Takman. Thank you,
Thank you.
Shital. We'll proceed with the hand section, and we have Simon McLean from New Zealand taking over. Thank you.
Thank you, everyone, for joining us. Melanie is going to give the introductions of the speakers.
Thank you, Simon. So first, let me introduce our first speaker, Dr. Yang Kun Lee. He's an associate professor of the Department of Orthopedic Surgery, Research Institute of Clinical Medicine of Jeonbuk National University, Biomedical Research Institute of Republic of Korea. He's also the director in the Korean Society for Surgery of the Hand, Korean Society for Microsurgery, and the Korean Society for Surgery of the Peripheral Nerve. He's also a founding member in the Asia Pacific Wrist Association. Over to you, Dr. Yang Kun Lee.
Thank you. Can you see it? Can you see it and can you hear me?
Yeah, we can see and hear it well.
Okay.
Thank you.
Yeah, thanks, Melanie. I'm Yang Lee from Korea. Today, I'd like to talk about the treatment of ischial tendinopathy using a wrist arthroscope and often surgical repairs. The ischial tendon and the subshoots are important extrinsic stabilizer of the dialysis, and additionally, the flow of the subshoots is a crucial stabilizer of the TFCC. As you know, that the ischial tendon is highly susceptible to trauma due to its anatomical characteristics. And furthermore, both ischial tendons and the TFCC can be damaged by injury. However, it is difficult to differentiate the progression of ischial tendinopathies from the traumatic TFCC injury. Therefore, accurate diagnosis and proper treatment are essentials. The ischial tendon originates from 2 to 6 centimeters from the extensor retracculums, and it travels the takes the fibrocell tunnel at the ulnar heads. And it is stabilized by bone, fibrocell sheaths, and extensor retracculums. The fibrocell sheaths are anchored to the ulnars, and it is essential for the maintaining the tendon in its normal positions. The extensor retracculum is known as separated structures, and it is not anchored to the ulna, but it inserts in the ulnar aspect carpal bones. It is known as not a primary stabilizer, but it compressing force the ischial tendon in its grooves. The role of each tendon varies depending on the forearm positions. During pronations, it located the palmar and ulnar side of the ulnar head, passing through the pivotal cells sheaths in a straight direction, thus contributing the minimal force to the wrist extensions. But during supination, it moves dorsally to the extent of these minimi tendons, and at full supination, it exits the pivotal cells sheath with 30 degrees angles, thus contributing maximal force to wrist extensions. At this point, the tensions on the issue subsheath increased. Therefore, if the patient has issue subsheath instability, the patient may feel the pain during the supinations, and you can see the sometimes issue subluxations at the full supinations. Moreover, the issue subsheath is an integral constituent of the TFCC. Thus, the issue subsheath injury is often associated with the surrounding soft tissue, especially the TFCC. Malone et al. Described that due to the complex anatomy of the TFCC, the usually destabilizing injuries usually lead to the damages, not only the TFCC, but also the issue subsheath and other intra-articular structures can be concomitantly injured to varying degrees. In their studies, among the 42 TFCC injury patients, 28 patients had concomitant issue subsheath injury and issue subluxations. Allen and Lee also described the concept of multi-component injury of the TFCC. For restoration of the ulnar wrist stability, all pathologic components should be repaired, and they stress that the recognition of this extensive spectrum of injuries is essential to optimal management of issue subsheath disruptions. Until now, I have 18 patients who were treated surgically for issue tendinopathies. Among them, we could find TFCC injury in 5 patients. Among them, 3 patients have TFCC central injury. One of the patients have concomitant foveal injury, and 1 patient have only foveal injury, and the last 1 patient have dorsal peripheral tears. For clinical assessment, tenderness of the issue tendons and aggravated pain by provocative test and the swelling along the issue tendons are hallmark of issue tendon pathology. Sometimes you can feel the cracks of the issue tendons, and you can see the issue tendon subluxations. However, I think that it is difficult to differentiate this finding from TFCC injury based on only physical examinations. Sometimes you can find calcification along the issue tendon on French radiographs. However, it is also difficult to diagnose issue tendinopathy with French radiographs. Therefore, many doctors using ultrasound and MRIs are usually used for the diagnosis issue tendinopathy. On ultrasound, you can find anechoic fluid around the tendons and tendon subluxation or dislocations. On MRI, you can find the tenosynovitis and tendon ruptures and other structures injuries. But you know that the MRI is usually accepted that it has limitations for diagnosing carpal instabilities, especially in a post-traumatic patient due to the post-traumatic changes. However, the wrist arthroscope is known as a gold standard diagnostic tool for evaluating carpal instability. Therefore, I strongly recommend the wrist arthroscope for accurate diagnosis and treatment. In fact, in my paper, I could find that the patient physical examinations and MRI findings and operative findings were quite different. Although the MRI shows the degenerative peripheral tears, but with the wrist arthroscope, we could find the foveal tear. I think there is an individual radiology department threshold for diagnostic ability on MRI. Therefore, I strongly recommended the wrist arthroscope for more accurate diagnosis. Again, issue tendinopathy can be classified into tenosynovitis, tendinopathy, and instabilities. The injury mechanisms is direct blower, excessive stretch, or repetitive overuse. Initially, it caused inflammation of the tenosynovium. As disease progressed, the tendon become dense, leading to the stenothrombosis tenosynovitis. Moreover, if there is a subsist rupture or subsist loosening, the tendon become unstable and can be dislocated, and it will lead to the tendon ruptures. Additionally, in patients with anastomoid process fracture, you can find the issue subsist ruptures. The initial treatment for issue tendinopathy is usually a conservative method. If there is no any improvement with conservative treatment, we need to consider the surgical treatment, that is 6 dorsal compartment release. I usually perform the zigzag incisions. Before the issue of tendon explorations, I always perform the wrist arthroscope to confirm the intraarticular pathology, and then I incise the retinaculums and the subsist and examine the tendons for any abnormalities or tears. Then I only perform the debridement and the primary repairs without any reconstructions. I showed some cases. 46-year-old female patient in a past history 4 years ago. He was hurt her left wrist during golf. Fan radiograph shows the calcification along the issue tendons, and on MRI, could find severe tenosynovitis and TFC foveal injuries. During the arthroscope, we could find the severe synovitis at the fistuloid recess areas, and we could find foveal instabilities. So we performed the sinopectomy, and we performed the debridement, including the TFCC. And then subsequently, we opened the issue tendons and the TFCC foveal repair with suture anchors, and then we performed the debridement and repair the tendons and the subshoes. 54 months follow-up, she shows an excellent result, and the X-ray also shows the clean views. 64-year-old female patient admitted to left wrist pain. The pain was more aggravated 4 months ago. Frame radiograph, you can see the small osteolytic lesions at the elastoid process tips, and on MRI, we could find severe inflammation surrounding the TFCC and issue tendons. During the arthroscope, we could find the TFCC central perforations and the TFCC peripheral tears from dorsal and olar side, and foveal tears, and intraarticular severe inflammatory changes. And in this patient, I can see the issue tendons from the joint. And then we open the issue tendons, and then the TFCC foveal repair is the suture anchors, and the subsist repair is the suture anchor. Then perform the tenosynoviectomy and the issue tendon debridement and primary repairs. 25 months follow-ups, she also shows the excellent result. One more case is a 32-year-old male patient admitted due to the list ulnar side pain, swelling, and local heatings. The pain started from 4 years ago. The brain X-ray shows the lococarpal joint mild arthritic changes and the TFC central preparation, and we can see the issue tendon ruptures and ulnar head subchondral cyst in the ulnar heads. And then during the arthroscope, we could find the TFC central preparation, lunate cartilage defect, and orocarpal arthritis. And then we often the issue tendons. The issue tendon was partially ruptured due to the osteophyte of the cyst. So we treated the cyst and the cyst hole repaired with retinaculums, and the tendons was debridement, and we performed the primary repairs. And 14 months after the operations, she has a residual pain in the ulnar side during the walk. So I performed the ulnar shortening osteotomies. 33 months follow-ups, she had a excellent result. In summary, for my combined injury patients, in addition to this intact issue tendons, I performed only arthroscopic sinupectomy and repaired loosened issue subsets. And in cases of issue tendon and subsets partial rupture patient, I performed issue tendon and subsets repair and simultaneously repaired the TFCC in 4 patients. Summary. The incidence of TFCC ruptures associated with the issue tendinopathy has not been exactly known. However, issue subsets is recognized as an integral part of the TFCC. So I believe that TFCC injury likely to occur with the issue tendinopathy. Therefore, I recommend that when we treat the patient with issue tendinopathy, the possibility of TFC's combined injury should always be considered. And if the surgical treatment is planned, I recommend it to perform the wrist arthroscope for a more accurate intra-articular diagnosis. Additionally, I believe that simultaneous repair of the issue subsets, TFCC, and the intra-articular physiological structures to better issue and DLUJ stability would lead to favorable result. Thank you for your attention.
Okay.
Thank you very much, Prof. Lee. That was a fascinating talk on your technique there. We've got a few questions coming in, so we'll just ask a couple of those. Stuart Proper has asked, do you do a dry arthroscopy or do you always insufflate with fluid?
I usually use using the fluid, not dry arthroscope. Yeah.
Okay. And Justin Chow has said, in terms of how you repair it, where do you put your anchors? How many anchors do you use? And what position do you put the wrist in when you do the repair?
Often repair, phobia repair, I use only one anchors and phobia reasons. Maybe I think is one stitch is enough for the phobia repair. So I use only one. In second case, in the X-ray, I use 2 anchors, but one is phobia and one is subshoes pro repairs. Yeah.
Okay, and in terms of repairing the actual subsheath, do you use anchors for that as well?
Yeah.
Yeah.
The patient is all bone and the subsheath is detached. So I put in the bone. So at the time I use the anchors.
Okay, thanks. I think we'll move on to Jeff Ecker. So Jeff, if you'd like to give your talk.
Hi, can you see the slides clearly?
Yeah, that's good.
I'm going to talk to you about ECU instability, but a very rare variant, longitudinal intervesicular separation and loss of concentric integrity. But we're going to run the gamut from the simple ones to this really rare, unusual instability and also spontaneous rupture. So tendon morphology, you can see the vesiculi, and this is the simple instability, one where the tendon pops in and out of the sixth extensor compartment. But when we're looking at ECU instability, we need to realize that 42% of asymptomatic tennis players have asymptomatic ECU instability. And in my clinic, I see quite a few people coming in after ECU repairs, which are really repairing something that was a normal physiological anatomical variation. So it's abnormal, a normal anatomical variation. It's the same on the other side. It's only significant if it's asymmetrical and painful. The symptoms are mechanical ulnar-sided wrist pain, which occurs with pronation and supination. And there may or may not be a snap or a click. Now, this is easy. You can see the ECU tendon snapping in and out. It's asymmetrical, it's tender, and it's painful. Professor Ken Lee has shared this paper with you, which talks about the importance of the ECU sheath, but predominantly the distal part of the ECU sheath and the sixth extensor compartment. This is what the anatomy looks like. It's actually fascinating. We don't have time to go through it, but the extensor retinaculum inserts onto the pisiform and the triquetrum. It has extensions that go into the dorsal radiocarpal ligament and the dorsal intercarpal ligament, and these join with a very thick, dense floor of the sixth extensor compartment. It's fascinating anatomy. So if you've got a straightforward ECU instability, you can lift up an only based retinacular flap. Be careful not to damage the ECU sheath. You can lift up the ECU sheath, and here I'm using some anchors, and I'm simply going to reattach the ECU sheath there to stop the tendon dislocating. So once I've done that, I'm actually going to repair the extensor retinaculum. You can see it's already stable. So it's important to get an anatomical repair. And you'll also see there's two sutures in the wound. So you can get, if the sheath's intact, you can get a very nice anatomical repair. And here I'm tying the TFCC repair and the scapholinate repair. As Professor Ken Lee explained, it's not uncommon to have associated ligamentous injuries. So what we've done is a combined arthroscopic procedure. We've repaired the dorsal peripheral tear of the triangular fibrocartilage. We've left the sutures hanging out, and we've done a dorsal scaphotriquetral imbrication of the extrinsic ligaments to stabilize the perilinate scapholinate instability, then gone on to repair the simple instability of the ECU by repairing the sheath and getting an anatomical repair. So the bone morphology makes no difference. You don't need to make a trough. But it's not always that easy to diagnose ECU instability. And with ultrasound, we've got a high resolution ultrasound, the same quality as the radiologists have in the radiology clinics. And we go to this routinely. If there's any doubt, if there's any problem, we go straight to the ultrasound. And that's made an incredible difference to our ability to examine the wrist. So now we're going to talk about a rare problem of instability in the ECU tendon, longitudinal intervesicular separation and loss of concentric integrity of the ECU tendon. It's quite a unique form of instability. And what happens here is the fascicles separate, and they separate into a flattened tendon. And then you may go on to develop a rare form of instability where the tendon subluxes over the ulnar stylo with pronation and supination, and then the tendon follows and it reverses. And you can see it here on ultrasound. Here you can see me examining an ECU tendon, and you can see how it separates and goes backwards and forwards. It's a very difficult thing to describe, and this is why we called it longitudinal interfascicular separation with loss of concentric integrity. Once these tendons do this, they'll exhibit a squish test, and you can see how this tendon's, it's like an inverted palindrome. It goes one way, and then it goes the other way with pronation and supination. On the ultrasound, you can feel it flick underneath the ultrasound probe. And this is what it looks like on the MRI. And here it is when you open it up. It's almost like a noodle tendon. So let's get back to ECU instability with longitudinal fascicular separation and loss of concentric integrity. I don't know what to call this. Maybe somebody can give me a suggestion on the chat line, but we just call it Lis loci. And we just made that up because it's just much simpler to say. But I look forward to anybody else if they've got a better suggestion. And here you can see the tendon. It's longitudinally separated. And the first thing is to repair the tendon. So it's a longitudinal blanket suture. And then make sure the distal ostia is intact. If that's loose, you need to repair it. I've not had to use a tendon graft for it, but if I did, I would. I just, not a tendon graft, flip over retinacular flap. The ECU tendon needs to slide proximally and distally, dorsally and ulnally. So you want a smooth sliding surface, and you want a good blood supply to facilitate tendon healing. And what you can use is a fascial fat flap based on the posterior interosseous vessels. It's very simple to elevate, and this is real time, and you can see the vessels running into it. And what we're going to do is recreate the sheath, because there's no sheath there to repair. And then you can wrap it around the repaired tendon and repair it to form a tube. Now you don't need anchors. You can reattach the tube to the soft tissue on the dorsal side of the tendon and then reattach that sheath to the distal ostia. And then we're going to reattach the extensor retinaculum. Here we're just stitching it up to the dorsal soft tissues. So it's got some support. No need to use anchors, no need to deepen the trough or make a longitudinal tunnel on the bone. And at the end of the procedure, we've got a stable repaired ECU tendon. It's got a vascular sliding graft for a smooth surface and good blood supply. And this is what they look like when they get very severe. Now, therapy is really important. We work very collaboratively and together with the therapists. 1 to 3 weeks above elbow thermoplastic hinge splint. Week 1 to 2, they start controlled supervised active wrist motion. Week 4 to 6, below elbow thermoplastic splint. Week 7, they start a wrist proprioceptive strengthening program. And in our clinic, we always check their power and function at 3, 6, and 12 months. But it really is a collaborative piece of work between the patient, the surgeon, and the therapist working together. So this rare form of Lis loc, or whatever you want to call it, to give you an idea of how rare it is, over 3 years we did 340 wrist scopes, and we only found 7. So it only occurs in 2% of cases. So it's very rare. Now, as Professor Ken Lee pointed out, it's rarely isolated. Those 7 cases, 3 had a triangular fibrocartilage tear, 1 had a scapholunate injury, 2 had a triangular fibrocartilage tear and a scapholunate injury. And all of these were repaired arthroscopically at the same time using a combined open arthroscopic technique. And once again, as Professor Ken Lee pointed out, the clinical examination and the arthroscopic examination are invaluable in getting a full information base and completing an anatomically specific repair. Only 1 was isolated. So beware when you're repairing this kind of instability or any kind of ECU instability, that you have the full picture and how important the arthroscope is in making this diagnosis. And here you can see a complex volar tear of the triangular fibrocartilage. I'm in the TFCC, and that's the intact foveal ligament using dry arthroscopy. Pisiform triquetral joint. With dry arthroscopy, you get the most incredible view. There's the ECU sheath in the meniscus homologue, and that's torn. And as we come up it, there's a peripheral trigger C tear, and there you can see the ECU tendon. The meniscus homologue and the volar part of the ligament complex is completely torn. And then it's a very simple thing just to repair it. It's a dorsal peripheral tear. It's got a positive hook test, but we know the foveal ligament's intact. And I commend you to read an article on dry arthroscopy in the Journal of Wrist Surgery, which shows you how to do dry arthroscopy simply and quickly. And then once you've got it repaired, you can do your open repair. You just got to make sure you don't cut your arthroscopic repair. Here you can see the foveal insertion doing dry arthroscopy, slipping around the tear into the ECU sheath. Now, you do not need arthroscopy to examine the ECU tendon. You know it's unstable, you know it's degenerate before you start. You've got an ultrasound, you've got an MRI scan. But what I'm showing you here is the beauty of dry arthroscopy and what you can see. And again, you can slip around the foveal ligament and the detachment and into the ECU sheath and down. That's all the ECU tendon. So, you know, it's just a fascinating way of looking at things with dry arthroscopy, but that's unnecessary. It's just out of interest. So this is really a global injury. You know, pinched Greg Baines model and extended it to include the ECU sheath. So whenever you are dealing with any sort of a wrist ligament injury, scapholunate, perilunate, triquetral floating lunate, TFCC tear, always think of the ECU tendon. Otherwise, you'll miss it and get caught out. So in 3 years, we did 7 cases. So it's pretty rare. The DASH went from 36 to 13, PRWE 46 to 11, BAS at rest 1.9 to 0.3. This is the big one. BAS on use 7.4 to 1.9. And the range of motion, we didn't lose any range of motion. It was good. Gross grip 30 to 35. And here's the biggie again. Supination strength 68 to 109 kilograms. Pronation strength 42 to 87 kilograms. And here you can see the power outcomes. Green before, blue after, supination and pronation. So it's been very effective in dealing with the problem. But I must emphasize that we not only repaired the ECU, we repaired all the other injuries in the wrist arthroscopically. No recurrent instability of the ECU, no revisions of surgery on the ECU. So it's a rare form of intratendinous ECU instability. It's very easy to miss. Mark Garcia-Alias has added it into his 4-leaf clover because of how easy it is to miss if you don't think about it. To get an accurate and complete diagnosis, you need to pay attention to the symptoms, the clinical examination, the imaging, and the MRI can have false positives and false negatives, particularly for TFC tears and scapholunate instability. Dynamometer measurement, we find that crucial before and afterwards, and arthroscopic examination. And these two, the clinical examination and the arthroscopic examination, are absolutely imperative. You need all the components of this to get the diagnosis. You can't leave one out. So we call it list lock. We can't find a better term. Almost associated with other wrist pathology, combined open and arthroscopic surgery. Don't forget, it doesn't have to be arthroscopic or open. You can do it together. Gives you an accurate diagnosis and an anatomical repair. Open surgery, ECU repair, ECU sheath repair to create a vascular sliding fascial fat flap and increase the blood supply to facilitate healing, and make sure you repair the distal ostia of the ECU sheath in the 6th extensor compartment in the extensor retinaculum. And in our series, we got pain-free pronation and supination, and we got normal power of pronation and supination, which we found was excellent. So just a quick note on ECU rupture. Here you can see something that spontaneously ruptured their ECU. And what we've done is done a turn down graft using the ECU. You don't need to go to palmaris longus or semitendinosis. And then we're going to use a fascial graft because the floor of the 6th extensor compartment is rough and irregular. And we want to get a nice sliding fascial vascular flap for our healing. And then we can repair our tendon with our graft, our turn down graft, and then reconstruct the sheath and then the extensor retinaculum. And again, you can see sutures in the dorsum of that wrist. I've got sutures in the TFCC and the scapholunate ligament. So you don't want to do a half job and then we'll just repair the we'll tie the arthroscopic repairs after we've done the open one. So thank you very much. Welcome any questions, and particularly if somebody can give me a good name for that rare form of instability. Thank you.
Thanks a lot, Jeff. That was a great talk and some fascinating videos and surgical options there. We've got a few questions. I'd just like to ask Prof. Lee, obviously you do a lot of direct repairs for some of these injuries. Have there been any cases where you go in and you find the tissue quality is not good enough, or it's all stretched out and attenuated, and you need to do a reconstruction option? And if you do, what type of option do you use? Can you hear me there?
Simon,
Yep.
your question is if there any the tendon quality is low, the issue tendon itself a reconstruction method.
Yeah.
Maybe Jeff Eckert answer the questions.
Okay.
Henley and I are very good friends, and he's handed the ball to me. The question is vague. What tissue is not reconstructible? What tissue are you talking about? What are you asking? That's a confusing thing. Is it if it's the ECU tendon and it's irreparable and it's just noodle tendon, there's nothing there, you can't repair that. It's really simple. Do a turn down graft. If you haven't got enough of that, I go to semitendinosis. It's a fantastic graft. You need to make sure that your repairs are good. You need to make sure the distal ostia is firm, because that's the key to your instability. If you've got irregularity and you've got a rough floor to the extensor tendon, the sixth extensor compartment, then I'll use a vascularized sliding fascial sheath. Now, that's not a common operation. You only use it when you've got degenerate tendon, you need to increase the blood supply, and you need sliding. So for me, that's just straightforward. And if you don't have enough extensor retinaculum, you can turn a flap over. You need to preserve the extensor retinaculum. It is so important, but you can turn a flap over and it can be ulnally based and you can flip it back on itself. But then the next question is, what about the degenerate tissue inside the wrist? Well, I can tell you now, if you look at our article on dry arthroscopy of the wrist joint and the hook test, you'll know that only 7% of patients who've got a hook test have a foveal tear, and it's irreparable. So you don't even have to scope it. You know the foveal ligament's going to be there. But if the foveal ligament is gone and you've got a big, deep peripheral tear of the triangular fibrocartilage, then you need to do a reconstruction. And for me, it's an arthroscopic tendon graft reconstructing the fovea. And it's a very, very successful operation. It's difficult to learn, but once you get it, it's easy. But the recurrence rate after, it's rare. You only ever have to do it in about 5% of cases. And if you've got irreparable scaphoid instability, then you need to deal with that. And sometimes you will not get a normal wrist. That you have to be very honest with people. There's some things you can reconstruct. There's some that you can't. And as you get increasing complexity in your carpal instabilities and tears, your outcomes are going to be affected. But I hope I've answered the question.
Yep, that's good. Thanks, Jeff. Another question from the Q&A box from Hyun Lee. So when you open the subsheath, which side do you prefer, the radial or the ulnar side?
Is that for me or Ken Lee?
That's either of you.
Yeah, I usually often issue subsheath in the central areas, not confined any navial and ulnar side, but issue tendons over the issue tendon sheaths inside. Yeah.
I actually lift the extensor. It's a really delicate dissection because sometimes you can't separate it. Sometimes the sheath's not there. But if the sheath is there and it's a straightforward, simple instability, it's important to lift up that ulnally based flap carefully, microsurgically elevate it off the sheath. And if they've got an intact sheath, I lift the sheath up from the palmar side and keep it intact and then use that with the anchors. But everybody has their own technique. And all that matters is you do it as atraumatically as possible, you repair it, and just as importantly, look after the therapy afterwards. That's just as important as the surgery.
My incision technique is cut in the shape of the step cut incisions. Yeah, this is
Okay. We see this injury quite a bit in golfers. Certainly, that's been my experience, hitting bad shots in the bunker. In terms of time to return to sport for some of these, it obviously depends on the technique you've used. Have you got any rough guides?
Yeah, absolutely. The thing of what we do is, first of all, you've got an isolated ECU, but you're going to find a lot of them have got a global injury to the wrist or a partial global injury to the wrist. So you repair it, you rehab it, and as I showed in my slide, 6 weeks after the surgery, you start a wrist proprioceptive exercise program. And what we do is we measure their strength before and at 3, 6, and 12 months. And usually at about 4 months, their power profiles come back. So we'll measure particularly pronation and supination and force plate. They're the real key ones, not so much growth grip, because if there's any, they're the ones that really show you what's going on. So once they've got their power back, then they can go back and play golf. And it's, you know that they've made it at that time. So the other thing I'd say is that we talk about balancing the wrist, you know, antagonist and agonist muscles, but it's more complex than that. It's all about neuroplasticity. And that's where your therapists come in with their proprioceptive programs, because they train the brain to balance the wrist and then include it in their overall core function and their ground. And I think that makes a really big difference. And the concept of one muscle versus another muscle is too simplistic. The brain's too complex, but it's easy to train if you give it the tools and fix the wrist the way it should be.
Right, thanks. I think that's probably it in terms of time for questions, unless Melanie, you've got any final points you want to raise?
Not really. No, I think, thanks.
Okay. Thanks
Thank
a lot for the speakers.
Pleasure being here. And good to be with Ken Lee at the same place. We're both in Perth, looking over the river in the boat. So it's a lot
I'm
of fun.
impressed.
Superb.
Bye-bye.
Thank you.
So now we'll move on to the last part of today's talk. Thank you very much for staying with us. Now we move on to the elbow part. My name is Derek. I'm an orthopedic surgeon here in Singapore. I've done my fellowship in France with Santi, with Sonic Quartet, with Lana Neaton, also with Jules Vache. Today on this part, we'll be having three guests with us today to talk about distal elbow, distal biceps ruptures. Firstly, our commentator for today is Dr. Fan Chun Yi. He's a chief physician and professor at Shanghai Jiao Tong University and vice president of Shanghai Six People's Hospital, director of the Shanghai Engineering Research Center for Orthopedic Material Innovation and Tissue Regeneration. And next up, we've got Dr. William Xiatan. He's from a consultant orthopedic surgeon from Singapore General Hospital. He completed his shoulder and elbow fellowship in UCL in London with Dr. Simon Lambert. He has a keen interest in shoulder and elbow conditions, including trauma, sports injury, and degenerative diseases as well. And lastly, we've got Dr. Kelly Pua, who is a consultant orthopedic surgeon practicing at Artisan Sports and Orthopedics Clinic. Prior to transitioning to private practice, he was with sports service at the Department of Orthopedic Surgery at Singapore General Hospital, and he has done his fellowship with Dr. Laurent Lafosse, Professor Ralph Hertel in Switzerland, and Dr. Felix Paris-Savoie. And without further ado, I think we'll start with the first talk today by Dr. William Xiatan, who will be giving us a talk on distal biceps reconstruction with tape and button. Dr. William, thank you.
Hi. Derek, you can hear me, right?
Yes,
Hello?
we can.
Okay, that's great.
Yeah.
Yeah, thank you very much for the intro. So it's a great honor to share my experience in distal bicep augmented repair. So I'm going to start my presentation with a case. This is a 42 years old male. He's an enthusiastic bodybuilder with right hand dominance. So he presented in the clinic, heard a pop sound over like left elbow during heavy lifting. So on examination, we can notice there's a bruise over the distal arm, and also the hook test as well as the reverse pop ISI is positive. So I think we have a thorough consultation in the clinic. Patient is keen for surgical repair because I think the examination and mechanism injuring the examination is quite clear. So we didn't really do a pre-op imaging like MRI scan or ultrasound to further evaluate the tendon. So I think it's already diagnosed by clinically complete distal biceps rupture. So eventually we schedule surgery about 6 weeks after the injury. So after patient is under, so I'm on the arm board, and we have a transverse incision about 3-4 centimeter distal to the antecubital crease. Then we go into between the brachioradius and the pronator teres to find out the stump of radial tuberosity. So as we can see the anatomy here, along the way we may need to ligate some of the superficial vein or recurrent radial artery. However, we have to be very careful to protect the nerves, especially the PIN. So in this case, because it's 6 weeks, but at the time of surgery, 6 weeks after injury, there's some contraction of the proximal biceps. So I need a separate proximal incision to find out the rupture end of the biceps. So that we can see, this is the in-shot video. So by the time we find out the end, we do the debridement, the scar tissue, we tag the tendon end. We notice like the tendon is quite thin. It's worse than we expected. So decision was made to proceed with the augmentation with synthetic tape. So this is a technique. We use poly tape. It is a non-absorbable polyester with a porous design, which facilitate the soft tissue ingrowth onto this tape. So as we can see here, proximal and distal. So we pass the tape through the muscle and junction, muscular tendon junction. Then we cross them twice. Then after that, we wrap the tape around the distal tendon to consolidate, augment the repair. So we can see this is a in-chop radio to show when the tape is passed around the thin distal bicep tendon. Next, we need to incorporate I use a cortical button for the repair. So I use fiber wire, like 2 independent sets, go through the endo button, use a whip stitch, pass through, so one ending from proximal to distal, pass through the endo button, then go back to the proximal side, and another independent fiber wire goes through again. So to secure the endo button. And when doing this stitch, to make sure the space of bicep tendon end and endo button is around like 2-3 mm. So this allows the endo button to pass through the cortical tunnel and can do the flipping of the button at the end of the surgery. So here we can see once we complete the endo button, incorporate the augmentation with tape around the distal biceps, we can see the diameter is significantly larger. So now we come to the bone tunnel part. So as we can see, this is the footprint of over the radial tuberosity. So when you do usually when do the bone tunnel, so usually we need to hyper-supinate the forearm. We identify the footprint. Then I use a 4M drill bit at the center of the footprint. So my construct is I use 4mm, do one drilling first. So the far cortex, the size of bone tunnel is 4 mm. Proximally, I do 2 drill hole to create a tunnel, like a space. So it's about 8 mm. So this allows the whole stump of distal biceps to sink into the canal, which is maximize the contact surface of the distal bicep tendon to the bone to facilitate the better healing after the surgery. So once we use a passing pin, we attack 2 sutures. Then we use a passing pin, pass through this. Once the endo button pass through, very similar to ACL, we can flip the tendon, the button, to make sure it's well secured. So this is the in-chop image to show the button has been passed through the far side of the bone tunnel and secured very nicely. So at this step, we do a II to confirm the position of the cortical button there. So this is the wound after we wash and close up. So after the surgery, I usually use a Jones bandage to wrap around elbow for about 2-3 weeks. After that, we start very gentle passive movement of the elbow, but only after 6 weeks we start concentric training, gentle movement of the elbow. Then beyond 3 months, I start eccentric exercise and some muscle strengthening exercise beyond 3 months. This patient with the last review 6 months after surgery, the wound has well. The range of motion is about 10 to 130. But of course, at this point in time, I think still with more physio, there's space to improve the range of motion. Patient complaining slight weakness in supination. I mean, this is actually expected after the distal bicep repair. But I think with more physiotherapy, there's still space to improve further. So my plan is for when patient come back to review at 12 months to MRI scan to further evaluate how is the soft tissue healing with augmented repair. So I looking into the literature. Actually, there's very sparse data on distal biceps augmented repair using synthetic material. I can find one surgical technique notes using a BioBrace from America. This is to use BioBrace. It is actually a bioabsorbable polyester material to also augment the repair with a very thin distal bicep tendon and poor soft tissue quality. So in summary, I think this distal biceps augmented with synthetic material is a viable option in managing distal bicep rupture. With the data from of this biosynthetic material in rotator cuff and ACL reconstruction, I think the outcome is promising. Of course, future research is required to further evaluate the long-term surgical outcomes and post-op complications. Thank you very much.
Great. Thank you very much, Dr. William. I think we'll now quickly just move on to the next talk by Dr. Kenley Phua before we ask questions, if that's okay with everyone. So, Dr. Phua Kenley, if you're there. Okay. I'll hand over to
All
you,
right.
Dr. Kenley.
Yeah, you guys can see me.
Yes, we can see you.
Yep.
Hi.
Yep. So my name's Ken. I'm an orthopedic surgeon. I'm not a hand surgeon. So I mainly do shoulder and elbow and sports surgery. And I currently practice in Singapore along Orchard Road at Artisan Sports and Orthopedics Clinic, which is right over here in a nice shopping center. I've had prior experience in looking at distal biceps as part of my fellowship training. I've seen different ways of fixing the distal biceps. It's a relatively rare condition to encounter compared to the rest of our shoulder and elbow work. So I want to share a case of mine. And quite interestingly, in the course of preparing this presentation, I did one chronic one. I had a patient with a chronic distal biceps 4 days ago, and yesterday I did a acute biceps rupture. So we got stuff to talk about. My patient's a 34-year-old male, personal trainer, left-hand dominant. I was swinging on obstacle rings 1 month prior, heard a pop sound. There was swelling and bruising, the reverse Popeye sign, and on the hook test, there was an absent distal biceps tendon. This was the MRI. Which I got. This patient was referred to me by a colleague, so there was a bit of delay before coming to me, and there was already a tendon retraction of 9.4 centimeters as seen here on the MRI. And by the time I got him into the OR, it was 2 months after injury. So this was my plan. which was to open the distal site first, to localize the tube, localize where to make the skin incision under fluoroscopy over the radial tuberosity. And in order to locate the stump, I made a second incision more proximally. And after dissecting out the bicep stump, this was all I had left, which was not enough to bring down to the radial tuberosity as a primary repair. So I proceeded to pass an electron catheter underneath the tissue tunnel, and I took a semi-tendinosus allograft, did a Povertov weave to pass the graft through the stump as a tendon to tendon reconstruction, and then I added acellular dermal matrix at the musculotendinous junction because I felt this was an area of weakness. Then I proceeded to fix the biceps in the radial tuberosity in the usual way under fluoroscopy using a biceps button and interference screw. Rehabilitation-wise, he was placed on a hinge elbow brace. He's a physical trainer, so I didn't need to send him to a physical therapist. It was more of me and him managing the rehabilitation. So I started him off at 8 lock with allowing a full flexion, full active flexion, but limiting his extension to 80 degrees with a 2 weekly increase in extension about 20 degrees until he gets to full extension, which works out to be around the 6 to 8 week mark. After which he was taken off the brace, and he proceeded to take heavy loads at the 3-month mark. So this is at the 6-month mark, showing where the incisions were, and this is comparing left and right to show that I was able to restore most of the biceps contour. So the issue with a chronic distal biceps rupture, the distal biceps ruptures are not that common, and sometimes by the time they land in your clinic, it may have been some time. There is some disparity in defining what is a chronic distal biceps. What is defined as chronic? Most papers talk about anywhere between 21 days to more than 4 weeks. And the reason why we need to recognize this is because of the potential need for a reconstruction. And if we're not mentally prepared and physically prepared to perform a reconstruction, you might find it hard to get that stump back down in a safe way. Regarding acellular dermal matrix augmentation, it's not something new. This has been what we've been trying to do for the rotator cuff with SCR and now with cuff augmentation. In one of the papers described here, the acellular dermal matrix is wrapped around the stump. Of course, in the issue here is with our Asian patients, we may not be able to drill a big enough tunnel in order to accept a graft and the native biceps tendon in a single socket. And I felt that the musculotendinous junction, because that was where I did the Povertov weave, was probably a bigger area of weakness. That's why I placed the acellular dermal matrix over there. Quite similar to how I perform my pec major reconstruction. In terms of the Povertov weave, there have been different papers which have published their various techniques. The idea of using the Povertov weave, because it's a tendon-to-tendon repair, we are not relying on the sutures in order to hold the reconstruction together. As shown over here. What I did learn from this case was that length and thickness matters. When I asked for that semi-tendinosus graft, it was it was 21 centimeters. But by the time I did the weave, it still turned out to be tight, and I had to bring it into flexion. Use of fluoroscopy, both for placement of the incision and also for confirmation of the tunnel, and to ensure that the button has split, and to ensure that there's adequate tension. The PIN is near, and we'll talk a bit about this in the next slide, where if we're using the bicortical button construct, this is from a cadaver study. It shows that the PIN is 2 millimeters away from our exit point in 8 out of 12 cadavers, and this was a cadaver study. So the authors had an opportunity to cut open the opposite side to see where the button lay. And out of the 12 cadavers, one had a PIN caught under the button. For my change in practice now, I've tried to, when I drill the opposite cortex, I switch to oscillate as recommended by one of my German colleagues to try and minimize soft tissue injury on the opposing side, because that bit is done blind. There are other ways to mitigate the risk of a posterior interosseous nerve injury. One is to use all suture anchors and do it as an onlay technique. That has been published before. And the other way is to try and do intramedullary unicortical button, similar to how we repair the pec major, and similar to how some of us do our subpectoral biceps tenodesis. I tried it earlier this week. The problem I had is the biceps button is 12 millimeters in length, and our Asian population, it's the size of our radius. Most of the time when we are fixing forearm fractures, we're dealing with a lot of 12s and 14s for our bicortical screws. So I found that when I tried to flip it intramedullary, I was unable to due to our patient's anatomy. So this is where I am now at 2024. Because these cases are not that common, so when I get them now, I pull out all stops. When the preoperative ultrasound to mark where the stump is. Intraoperative ultrasound, if I'm not sure. Although I found this week that intraoperative ultrasound was not as useful as on-table ultrasound before making the skin incision, as the gas shadow from my own dissection started to confuse me, especially since I'm not an ultrasonographer. And liberal use of the arthroscope as inspired by Dr. Deepak Bhatia to perform part of the dissection in order to localize the distal bicep stump amidst the jungle of the antecubital fossa, and also to visualize the tendon going into the socket, which I find is always a bit scary. I've had the sutures snap before under high tension while trying to dock the distal biceps tendon into the tunnel. In summary, chronic distal biceps reconstruction, not common. However, quite often when we get a distal biceps case, there's a possibility that by the time the patient comes to us, we have to deal with it as a reconstruction. Because the numbers are small, so it's a technique in evolution. On one end, with buttons and suture anchors, I think we've tackled the mechanical strength part. Now it's about figuring out the biology. And with that, I thank you.
Thank you, Ken Lee. Before we move on to the questions, I think maybe I'll ask Dr. Fan if there's anything. If not, I think there's a question that's been posted on the Q&A.
Okay. Good afternoon, Dr. Guo, Dr. Pan, and Dr. Xia, and Dr. Jun. I found that Dr. Jun is in online, and
Dr. Fan, you're muted. Dr. Fan, you're muted. Dr. Fan, you're muted.
I'm sorry, Dr. Guo.
That's
I'm sorry.
good now. All good
Good
now.
afternoon, Dr. Guo, Dr. Xia, Dr. Pan, and Dr. Yinho, and Dr. Maclan. Good afternoon. My question is, first question is to Dr. Pan, and according to my experiences, I found that there maybe you can use the single incision or two incision. What do you think the single incision and the two incision? What do you prefer? And the second question is to Dr. Xia, and how to avoid the injury of the interossei nerve and the artery during operation. Okay, thank you.
And you want to go first?
Yeah, okay.
Okay.
Yeah, let's do that. Hi, Dr. Fan. So,
Hi.
if I can get the stump from a distal incision only, that will be my first choice. But quite often I find that it's retracted a fair bit. That's where a second incision is useful. The other thing that I can use the second incision for is if I can deliver the stump through the second proximal incision, it's a lot easier for me to prepare the distal biceps tendon, and I can pass sutures all the way up to the musculotendinous junction a bit easier. I've tried both ways. I tried making a longer distal incision. I tried making a L-shaped incision as well. I haven't exactly figured out which is the one that works best yet.
Okay. Do you have a long-term follow-up for the a cellular dermal matrix by to reconstruct the biceps tendon in what as you described just now? What's the results of the
Okay.
a cellular dermal matrix? What do you think about that?
I haven't had a chance to scan these patients after using the acellular dermal matrix. However, the tricky part I have is that I haven't had a touch wood a patient that has had a re-rupture yet, both with and without acellular dermal matrix. So I don't know how much it contributes to the biology, to the healing. However, because it is at least to me, it is quite a scary operation to do. I would not want to go in again a second time. So I would try and pull out all stops to get the tendon to heal. So if I'm using an allograft for reconstruction, I would want to put whatever biologics I can in because that weak area would be where the allograft meets the native biceps tissue.
Okay, thank you. Dr. Xia, would you
Oh,
please
hi.
tell me
Hi, Prof.
how to...
Yeah, so I think my question is how to avoid injuring to the PIN. I think Ken has actually shared quite a lot of his tricks and tips on this. So I think for me, one is to when you identify the radiotuberosity, so when you prepare the drilling, you have to hyper-supinate the forearm to really allow the PN to fall out of the surgical field of your drilling. Then when you direct your drill bit to the far cortex, actually to minimize the risk of PN, Ken actually just now showed a paper very nicely. It's only like several away. So you can actually direct slightly more proximal and ulnar because PN is actually go around the neck and goes to the posterior. So I think that would be also minimize the risk of PN injury. And also, I think for me, I feel if really you are in doubt, right? For me, I think the wound, I can make it larger. I have to visualize very well. I think we're not like, really like minimal invasive or this. The main thing is to really, you have to visualize them well, see everything clear before actually you do all these steps. If you're really in doubt, I mean, I'm not afraid to like just make a wound bigger to take the my surgery. Yeah, progression of my surgery.
Okay, thank you, Professor Dr. Shah. And I just want to know the difference, the different fixation method for the acute rupture and the chronic rupture of the biceps tendon. Do you think it is different?
Okay, so yeah, so okay, so the main concern for chronic is like the contraction of muscles, which actually you find it's very first to find it out and passes through. There's a big gap. So I think in the literature it shows if you really like surgery is well indicated, the preferred manner is to do it in the acute setting. Rather, you wait for patient coming in a chronic setting, which you need to add some like bridging, either allograft or even static material, which will increase the complication like re-rupture or this. So I think for me, if let's say I will evaluate patient's profile, the function demand, patient profile, this. If let's say surgery is well indicated and patient understand all this, I'll prefer to do it in acute setting.
Okay, thank you. Dr. Pan?
Thank you, Prof.
In your case, there's I think this chronic rupture of the biceps, and do you think it is enough the length of the biceps tendon is enough for the fixation, or use the allograft of the autograft?
Yeah, I think the if it would be better to use autograft. My concern with autograft is of harvesting. I think harvesting the palmaris longus, although it's an option, we have heard horror stories of harvesting the median nerve by mistake, and the caliber and length of the palmaris may vary. So if we want to harvest an autograft, if I would go for one of the hamstring tendons as my first choice, which would be the semitendinosus.
Okay, thank you, Dr. Pan. And do you think what kind of the patient can be treated by the non-surgical treatment? Do you think for example, the elderly people or these some people who have who is not having a walker? Do you think it is a good choice?
Yeah, so I have had patients who have decided not to go for surgery because they either have a very low demand, or being aware of the risk of nerve injury, the patient chooses not to take the risk, and would rather live with a bit of weakness. The main weakness most patients have is a weakness in supination. So if they have to do this action a lot, the open doors, open jars, that's the time when they feel that there is some weakness. The other thing about patients with distal biceps ruptures is a lot of these patients are patients who work out a fair bit. Most of the patients I encounter is through some sports or gym related activity, and they would like to preserve one, their strength, and two, the contour of the biceps, the appearance of the biceps as well. So the more active patient would want to go for surgery.
Okay, thank you, Dr. Pan. And Dr. Guo, is some question from the audience?
Yes, that's correct. I think there's a question from the audience from Justin Chow. His question to both the speakers are your surgical indications for partial distal biceps tear. How would you go about repairing it? And does it involve completing the tear first to expose the footprint? Maybe we start with Dr. Pua first.
That's a very interesting question. Because I haven't had the opportunity to have a patient with a partial biceps tear. We are all aware that the distal biceps tendon has two separate bundles that run down. And I have had one patient that had a tendinopathy with a partial rupture. However, because he still had his biceps contour, and he still had some strength, he decided he was gonna go for non-surgical management. As for a patient who has decided to go for surgery with a partial rupture, I have yet to encounter one. However, if I were to work this out, my best bet would be to try to preserve the native tissue as much as possible and preserve the native attachment as much as possible, so that there's at least that vascularized biology on which I can repair upon. Unless it's hanging there by a couple of strands, then it may be easier for preparation of the stump to resect the entire stump and perform a repair as a complete rupture.
Thank you, Dr. Pua. But Dr. William, do you have any comments on how you go about doing a partial repair?
Okay, so I think I don't think it's very common in our practice in Singapore. So I was lucky to see actually one case. So initially, so in the literature, actually, I mean, some of studies suggest like 50% rule. So less than 50%, more like recommend conservative. More than 50%, more like towards the surgical repair. So the case I saw previously is like initially started with less than 50%. I saw like it's referred from other center. There's some people going to do like endoscopic to do some debridement because some pain over there. However, over time, I think it's about like 1 or 2 years down the road, there's further tear and causing more weakness. Yes. Weakness and pain. So I think eventually we have to go in to because it progressed into a high grade kind of partial tear. So I think eventually we have to take down the remaining fibers and do it as a complete tear. Yeah.
Thank you very much. Are there any more questions? I think we've got about 1 or 2 minutes left. Maybe one last question. There's no one. Maybe Dr. Fan. If not, I think we've got a fair bit of discussion. I think it was a good discussion. If not, I think we'll end here and hand it back to the organizers.
Okay, thank you so much.
Thank you, everyone.
Thank you.
So thank you, everyone,
Thank you.
for the wonderful discussion and as well as the lectures. It's been very inspiring to all. I'm sure that the participants have learned a lot. And I'd like to share with you that if you do want to learn more besides keeping track of all our in the website and all our activities, you can welcome to come to Hong Kong for next year.
Okay, thank you.
And so this is a meeting for next year in Hong Kong. There's the APOA hand upper limb. So this is the meeting next year. So early bird registration extended to the 8th of December. It will be happen at the Hong Kong Academy of Medicine on the Hong Kong Island side, which is just next to the Ocean Park, which is a theme park, where you can see pandas and as well as other things. you are welcome to come to Hong Kong to join the meeting with shoulder, elbow, and wrist arthros. You're welcome to scan the QR code and see whether you have not arthroscopy, but also and have pathologies. So that we have ultrasound shop as well as a post-congress cataract workshop. If you want to have more details with the faculties and other speakers, you are welcome to the QR code and to find more information about that. So with that, thank you very much. I would like to remind you all that next year that there is the APOA meeting in Cairns as well in Australia, of which you're all welcome to join as well. So thank you very much again for listening, and we'll give you posted on other activities that we have at the APOA handle. So that thank you very much for coming, and thank you for all the organizations, for the scientific committee led by Jonathan, for all the work they've done, and thank you for all the faculties. Thank you. So maybe all the ones would everyone turn on the camera so that we have a group photo of some sort before we say. Who should be? Is somebody taking a photo? Yes, sir. Yep. Okay. So thank you very much for listening, and thank you. And so for the scientific committee, please, and the executive, please leave behind, and we'll have a short meeting. Thank you. Do we think we can close the meetings and just have the panel here? I mean,